Today I will explain why man and woman, different ethnic groups, should have different bone mineral density or BMD threshold for classifying osteoporosis. This is a short version for potential patients. Uh, so we argue man and woman, different ethnic groups should have different threshold. So first, I will explain some epidemiological evidence. This is study comparing Hong Kong Chinese women and USA Caucasian women. This is a hip fracture rate. You can see USA Caucasian women has almost double the fracture rate compared with Hong Kong Chinese women. This is the data for men. So the trend is the same. Uh, Hong, Hong Kong Chinese men had only half of the fracture rate compared with Caucasian men in USA. But we can see both for Caucasian and for Chinese, the fracture rate among men is only half compared with women. For example, this is half of this. And these are data from Sweden, Japan, and Hong Kong, women and men. You can see that uh, for Japanese and Hong Kong Chinese, the fracture rate are quite similar, but compared with uh, people from Sweden, um, Chinese and Japanese have only half of the rate compared with Swedes. This is woman, this is man. So man, again, the fracture rate is only half or even less than half compared with woman. This is the same. If we if we say white woman as 100 rate, then you see black woman only half, Asian only half, and then man, white man is half of white woman, and Asian man will be a quarter compared with white woman. But till now, the existing threshold, the value is the same for so for DEXA scan, which measure bone mineral density, and we can get a T-score. So the T-score for osteoporosis is minus 2.5. Okay, for male and for female, for Caucasian and for East Asian, and for femoral neck and the lumbar span. So all is minus 2.5, which is not reasonable. If we use a QCT, it's quantitative CT to measure BMD, then the current threshold for spine is 80 milligram per mil for men and for women, for Caucasian and for East Asian. This is again is not reasonable. So we propose adjustment. So that means men and women, femoral neck, lumbar spine, Caucasian and Chinese. We should have different threshold. And our results have been published in many articles, in many journals. Now, there is another issue is when we when we use DEXA and we get this minus 2.5 T-score, we need to use uh, normal young people's value to get the, this T-score for older people. We know osteoporosis mainly occur among older people more than 60, usually more than 60 years old. And for women, it will be after menopause. However, there is another issue. According to this, uniform Caucasian non-race adjusted female reference should be used to calculate the T-score for men of all ethnic groups. Uh, Now, actually, after this recommendation was published, this generated a lot of debate. For Chinese, for Asia, I mean mainly East Asia, the recommendation is uh, population specific values are available for some Asian ethnicities are advisable to use, okay, for evaluation of bone mass in them. And similarly, ethnic male normative database should be used to evaluate Asian male if available. So, this will cause an issue. For example, a person, let's say a Chinese in Hong Kong, if he is examined in Hong Kong, then he will use a Chinese male reference. Then if he travel to the States, then he will examine use a Caucasian female value. So this will be quite confusing. So this person can be osteoporotic in Hong Kong, also sorry, non-osteoporotic in Hong Kong. Then if he go to USA, maybe he's osteoporotic. Or this is same for women. For women, I if he's in Hong Kong, then a Hong Kong a women value will be used for the T-score calculation. If she go to USA, then a Caucasian value will be applied. It will lead to well, quite different result. So we argue that uh, the normal value to calculate. So if we want to calculate T-score for older people, we need to use the normal young people's value as a reference. So currently in Asia, East Asia, a Japanese reference is universally adopted in Japan. And to our knowledge, both local and Caucasian values are used in China, in South Korea, Taiwan, and Singapore. If a Caucasian normal value is used, then there will be an overestimation of osteoporosis. Okay. It says female reference. If a female reference is used to calculate for male patients, there will be a underestimation of osteoporosis. So this is our argument. Uh, we should use the patient's own gender and ethnic group normal reference. That means, let's say, yes, this is correct. A Japanese woman should use a Japanese woman, a female patient should use Japanese female reference. A Chinese a Chinese man should use Ch Chinese young people's reference, regardless this person is in Asia or in the United States or in Europe. So this will cause a problem. For example, let's say in the United Kingdom, um, then if the Chinese attend a hospital and he or she is examined using the UK Caucasian value, then there'll be an overestimation of osteoporosis. So, so there is another issue for the threshold. For the threshold, now we use minus 2.5. Okay, minus 2.5 is correct for women because hip fracture occur at minus more or less -3. That means if a patient attend the screening program and it's minus 2.5 or even minus 2.4, minus 2.3, then she will get a warning, you are osteoporotic. Okay, if the BMD further drop to -3, then on average you will likely to have a fracture. Okay, so this minus 2.5 is reasonable. However, for men, for men, the average fracture T-score is minus 2.3. Then if we use minus 2.5 to screen, it became probably not useful because on average, uh, when T-score is minus 2.5, fracture already happened because fracture occur at minus 2.3. Therefore, we suggest for men, the threshold should not be minus 2.5, it should be minus 2. Now, this is our data from Hong Kong. As you can see, this is minus 2, sorry, this is minus 2.1, minus 1, minus 1.5. The 2 um, minus 2. So when the value is higher than minus 2, for example, minus 1.5, the fracture risk is low. After minus 2, the fracture risk become high, right? Okay, so we recommend if we do a screening, then for men should not use a minus 2.5 threshold. Instead, should use minus 2 as a threshold. Uh, yes, for feminine, for female patient, minus 2.5 is correct. For male, we should change it to minus 2.5. For Chinese, female minus 2.7, male minus 2.1. So the difference is not a very different. Uh, Korean female minus 2.5, Chinese woman minus 2.7 is not very different. For Chinese man, minus 2.5, Caucasian man, minus 2. It's not very different, only slight fine adjustment. But as I explained, we should use the patient's specific gender and ethnic group threshold to calculate this value. For spine uh, QCT, currently is 80 milligram per mil for everyone. So we argue that for East Asian or for Chinese, This threshold should down from 80 to 50. It's a great difference. There are many reasons for this. I will give you some simple, straightforward reason. For example, this is a study um, done quite long ago by Ito. So at the age of 78, USA women, the mean QCT is 82 milligram per mil. However, for Japanese, it is only 40. So it's very different. These are consistent. For example, Italian, it's about 80. Korean, also about 50. This is Thai. This is Chinese. So there are many reasons. For very simple reason, at 80 years old, Caucasian has a mean QCBMD of about 80, but for East Asian, Chinese, Korean, or Japanese, we have only 40, 50. It's very different. So basically, if we use 80, then too many people, too many women, actually, yes, too many women will be classified as osteoporotic. And now it's 80 for everyone. So this citation is our study. We say you should adjust to 45 to 50. Then for men, so this 80 is like for men and for women. And we say for men and women, we should have different value. Very simply, men has a higher normal uh, QCT-BMD. If for women is 50, then Asian man is 68. Okay. And also these are the fracture BMD, the BMD value when fracture happens. And we can see that the man, okay, blue man, pink woman, man fracture at a higher BMD than women. Therefore, we say the threshold is 50 for women and Asian women. For Asian man, it will be 68, or you can say 70. Now, if we look at this graph, we can say Hong Kong male, if we use 68, the differentiation of with fracture and without fracture, it will look like this. Then if we use 50 to Japanese female, it will be look like this for with fracture and without fracture. And this is data from Germany, females with fracture and without fracture. The threshold is 80. So we can see female Caucasian 80, um, Japanese 50, Hong Kong Chinese male about 70. So differentiation is pretty much similar. Okay. So therefore, Caucasian women 80, Chinese women 50, Chinese men 68. Then we argue that for Caucasian men, 80 will not be applicable. We should use a threshold of 100 because the mean value man has about 20 milligram higher than women. And also man fracture at a higher BMD than women. Men fracture at a higher BMD than women. So that's our suggestion for Caucasian male 100, Chinese female 50, Chinese male 68. Of course, because there's a huge difference between the fracture rate between men and women, so the concept of osteoporosis. In women, there's no perfect, there's no perfect, the same concept in men. So if we use this ratio for men, because the lower fluctuate, therefore the specificity means actually how many will have fracture among men will be different from that of women. So for spine, um, we say for spine we say minus 2.5. It's not very good. We should use minus two. For Chinese female, this is male, okay. For Chinese female, we should minus 3.7. Male, no change. So this is also a huge difference. Another issue is currently we diagnose osteoporosis by either the hip BMD or spine BMD. But in real life, hip fracture is the most important fracture. Okay, hip fracture is the most important fracture. But spine BMD is a poor predictor for hip BMD. You can see this is a hip fracture lumbar spine T-score. Okay, female, male, female, male, and mixed male and female, Caucasian, and these are for East Asian hip fracture. So let's focus on um, Caucasian hip fracture. So because currently for female, the recommendation is a minus 2.5, right? The female. Then, however, most of the fracture occurred before minus 2.5 because we from zero to 1 to minus 2 to BMP drop, right? But most of the fractures occur before or with BMP higher than minus 2.5. Therefore, minus 2.5 is not a good predictor. So why we say man should be if woman is a minus 2.5, then man is a minus 2 because man fracture at higher BMD than women. This is value for East Asian women, mixed women and men and men. Therefore, therefore, if a doctor tells that you have a you have osteoporosis based on hip BMD, or you have osteoporosis based on spine BMD, the clinical significance is different. So, politic is hip osteoporosis or spine osteoporosis because hip osteoporosis has a higher clinical relevance. Spine BMD is a poor predictor for hip fracture. Uh, our results have been also published in this expert review. It's me. Okay, these are nice pictures. These are nice pictures from Hong Kong. Thank you.